Hello, everybody. Happy Saturday. This is Nurse Eunice, and in today's video, we have the hardest CNA and PCT practice test. We have 100 challenging CNA exam questions, and as we do in each of our videos, we're going to give you a few moments to receive your notifications, and we will get started shortly. All right, I see that you're coming in. Hello and good evening, everyone. Everybody, we have a wonderful resource. It is our CNA Exam Prep Study Guide. It is one of the best sellers on TikTok, and also it's one of the best sellers in our Amazon store. To purchase it, you can scan the QR code that's on the screen, or you can go to our website, which is fltraining.com. And for the hundreds of you who've already purchased it, thank you so much. Many of you contact us because you want to do more with your CNA license. And so, as a CNA, you can do more. Whether you want to learn phlebotomy, EKG, or maybe even become a medical assistant, you can do that. We've partnered with Career Step. Our website for Career Step is floridacareeracademy.com. And whenever you go to the website, just scroll down and you're going to see the information about our online medical assistant training program. It's hybrid. You can take the course anywhere from home in the United States, and then we will partner you with a clinical internship site so that you can get your hands-on training. And best of all, it's affordable. So if you want to do more with your CNA license, consider our online medical assistant training program. And then last but not least, this is one of our biggest, newest projects. I spent so much time working with Brainscape in order to create the new CNA flashcards. You all, they are phenomenal, and you can try them for free. Whenever you click on the link that's in the description, you'll see the link to Brainscape, but you can also use the QR code that's on the screen. And there are hundreds of questions via flashcard. That is very innovative and interactive, and I encourage you to try it today. And now we'll get started with our practice test. Question number 1. A resident on contact precautions needs to be transferred to X-ray. Which action best prevents transmission of germs? Is it A, place a surgical mask on the resident? B, wear gown and gloves and clean transport surfaces after use? C, keep the resident in their room and refuse transport? Or D, use an N95 respirator only? And I'm trying to look at the comments now. Hello, Tanisha. Hey, Vivian. All right, giving you a few moments to put those answers in the chat. There we go. Now I can see everybody. Hi, Richard. Revealing the answer in 3, 2, and that's right. When your patient has an infectious process, such as if they're on contact isolation or contact precautions, you would not need to wear a surgical mask. You will wear gowns and gloves when you transport that patient. Contact precautions requires the strict use of gown and gloves, and also any surfaces that patient may have touched, you're going to clean that with the hospital or facility approved disinfectant agent. So everybody who chose B, give yourself applause. Question 2. A pulse oximeter reads 84% on a resident who is talking normally with warm hands. What is the first step? A, immediately notify the nurse. B, offer oral fluids. C, apply lotion to the finger. D, recheck using a different finger and ensure that the probe is aligned. Hi, Mary. All right, we have a lot of you all studying your test. Don't be nervous, Tanisha. You're going to do great. The fact that you're here studying on a Saturday lets us know that. You're going to do fine. All right, let's see if we have any answers for question number 2. We're going all the way to 100. So revealing the answer in 3, 2, and look, you all, you have to recheck. So if the finger is warm or the hand is warm and the O2 sat is 84%, it may just be as simple as the probe isn't on the finger correctly. So yes, verify accuracy before assuming the value is true. Oh, and thank you so much for becoming a Study Buddies member. Thank you, Missy Lois. We appreciate you. All right, let's go to our next one, everybody. 3, which task is outside the CNA scope of practice in most settings? Is it A, measuring and recording urine output? B, changing an occupied bed would help? C, assessing lung sounds for crackles? Or D, assisting with oral care? And I expect everyone to get this one right. This isn't a hard one. You got to make sure you understand your scope of practice. And so someone put A, that measuring and recording urine output is outside the scope of practice for a CNA. Let's see what the others have. Giving you about 5 more seconds to enter your responses. That's right, Amanda and Mary, you have it. It is C. So you cannot auscultate lung sounds. That's an assessment skill that's performed by licensed clinicians such as nurses, doctors, and respiratory therapists. The most that a CNA will auscultate would be a manual blood pressure. So you'd be listening to the brachial artery. But everything else would be inside or included in the CNA scope of practice, except for listening to those lung sounds. That is a nursing function. Question number 4. A resident suddenly becomes pale, sweaty, and confused. The safest immediate action is to A, leave and notify the nurse. B, give them 4 ounces of orange juice. C, keep them seated or lying safely and stay with them until help arrives. D, remind them to finish eating their breakfast. All right, I was hoping I would trick at least one of you all with this question. I'll reveal the answer in about 5 seconds. Everybody got it right. No one stepped outside of their scope of practice. Everybody put C. So a lot of people just assume it's hypoglycemia and they want to treat. As a CNA, you don't treat first. You remain with that resident or that patient and you call for the nurse because a sudden change can indicate hypoglycemia, but it could be another condition such as shock. So to prevent any falls or injuries, you stay with the resident and notify the nurse. You never want to leave someone who is sick or in danger alone. Thank you, Jasmine, for buying your book on Amazon. I appreciate you. You all are so supportive. Question 5. Which entry is the best? A, resident was being difficult today. B, resident refused bath. Will offer again in 30 minutes. C, resident cursed me out. I couldn't help. Or D, resident was rude and refused a bath. Now, all of these may be correct. Residents will do each of those, but what do you want to document in the actual patient record? Revealing the answer in 3, 2, and yes, you want to do B. B is more objective. It's behavior-based language, and it actually says what you did. The others only tell what the patient did. The patient was rude and they refused to bath. Well, they still have to be bathed. Did you notify the nurse? So whenever you're documenting, it's just not what the patient stated or what the patient did. It's your follow-up. And sometimes as a CNA, you can't do everything. What you can do is you can offer again to give them a bath at a later time and actually document that. And now if they refuse the second time you attempt, that's when you want to get your nurse involved. 6, a resident on droplet precautions is coughing. Correct PPE for close contact is which of the following? Is it A, surgical mask and gloves, B, gown and gloves, C, gloves only, or D, N95 respirator and gloves for all tasks? Droplet precautions. So these are heavy particles that when the person coughs or sneezes, they don't travel far, they drop. All right, I see a lot of B's. I see gowns and gloves. Now we're seeing A's. I hope I don't mispronounce your name. So Sias and Amanda, I think you have it right. So we'll reveal the answer right now. And yes, for droplet precautions, you just need a surgical mask, the lighter weight mask. Droplets are spread. The droplet spread is blocked by a surgical mask. If they're coughing vigorously, you could consider eye protection. And of course, you're going to have on gloves when you're in the room taking care of that patient. So A is the correct response. 7, a resident is NPO but has a dry mouth. The best CNA action is to A, offer ice chips, B, provide small amounts of water, C, ask the resident to go to the bathroom and gargle with water, or D, provide frequent oral care with approved swabs. Okay, so this requires that you know what the abbreviation NPO stands for. And I see an A. Let's see if we have any other responses. We have a B. We have A's. So we're torn between A's and B's for number 7. And now Eloise and Emilia, yes, you all. So whenever a patient is NPO, that means that they cannot have anything by mouth. So the answer is D. The only way they can have ice chips or water is if there's an order that says NPO except ice chips or NPO except for small sips of water. But you have to think about the reason that someone is NPO. Either their stomach needs to rest because they've been vomiting, or maybe they're going to be going to surgery. So we don't want to be giving them any extra fluid, because if they have water on their stomach with sedation or anesthesia, they could vomit and aspirate. So that's the main reason why before a procedure, we say they can't have anything on their stomach. And then secondarily, don't have them go in the bathroom and gargle with water. Don't tip them with a whole bunch of running water, because I've seen patients who put their mouths under the running waters in the bathroom and they actually drank from the faucet. So you're going to just provide oral care. That's the safest option. 8, a resident with suspected C. diff has diarrhea. Best hand hygiene is which of the following? A, alcohol gel only. B, rinse with water. C, no hand hygiene if gloves were worn. Or D, soap and water after glove removal. And I'm so proud of you all for studying with me on a Saturday. I just like saying your name, Keo Paul. All right, I'm going to reveal the answer because this is an easy one. That's right. We have to use soap and water. The C. diff, it's a spore, and it's hard for the hand sanitizer to penetrate that spore. So hand sanitizer doesn't kill C. diff. So what we have to do is we have to use soap and water and the friction to wash it off of our hands and down the drain. So the best response is D. 9, which is a critical respiratory rate for an adult at rest? Is it A, 18 breaths per minute, B, 22 breaths per minute, C, 8 breaths per minute, D, 30 breaths per minute, E, both C and D, or F, B, C, and D? And that's a long one, so I'm going to give you 10 seconds. You have to know your ranges, because you could have 15 patients. And if you're counting their respirations, everyone's respiration rate should be different. And so which ones would you notify the nurse about right away? All right, we have a lot of D's. We have an F and a lot of D's. Anybody else? Revealing the answer in 3, 2, and the answer is E, everybody. So let's look at it on the next slide. So the 2 that are abnormal would be C, because it says critical. So it says whenever something's critical, that means that the patient would probably be deteriorating. So just because someone's respiration rate is 22 breaths per minute, that doesn't make them critical. I breathe at a normal, at rest, my breaths are like 19 to 20. And so if I go up to 22, yeah, it's faster than textbook normal, but that's not a critical respiratory rate. So the ones that are critical would be E, both C and D, because C is 8 breaths per minute. That's really close to zero. And then D, they're hyperventilating. And so your normal ranges for your respiratory rates for an adult would be 12 to 20. There is some room for people being human. So if it goes up to 22 to 24, you monitor, you let your nurse know if you're concerned. But if you go into that room and that person's respiratory rate is 30 and they're just sitting there watching TV, that would be something that would be critical and require immediate assessment. 10, a resident begins choking and cannot cough or speak. Per AHA choking response, you should do which of the following? A, start back blows only. B, give abdominal thrust until the object is expelled or until they become unresponsive. C, give 5 back blows followed by 5 abdominal thrust. Or D, perform a finger sweep immediately. Your residents in the dining room and they are choking and you're the only caregiver around. What do? We have F's, we have D's. See if we have any other ones. And it's okay if you overthought that one. All right, revealing the answer in about 5 seconds. Hey, Danita, I haven't seen you on here in a while. It's good to see you. All right, so we're torn between B's, C's, and D's. And according to the 2025 American Heart Association guidelines, we now do C. For adults, children, and infants, you start off by hitting the back first. So here's the rationale. According to the updated American Heart Association choking response, or when you're assisting somebody who's choking, when an adult or a child has severe airway obstruction, indicated by they cannot cough, speak, or breathe, you want to first deliver 5 quick back blows between the shoulder blades with the heel of your hand. If the object does not come out, you'll then give 5 abdominal thrust, and you'll continue alternating between 5 back blows and 5 abdominal thrust until the object is expelled or until the patient becomes unresponsive. Once they become unresponsive, if you haven't already called for help, do so, but you would immediately start CPR. And here's the illustration. So these are the newest guidelines. Adults, children, and infants, you start off with back blows first. 11, a resident is pregnant and choking with severe obstruction. After back blows, what is the next best action? Is it A, abdominal thrust, B, chest thrust, C, back slaps while seated only, D, place them in a recovery position? Your resident is choking and they're pregnant. Why would you have a pregnant resident? Because sometimes you have patients who may be residents who are in drug rehab. Maybe she needs assistance with medications. So not all residents are going to be elderly. Some of them are still young and sexually active. So you have a resident who is pregnant and they're choking. After back blows, you would do, yes, chest thrust. That's right, Amanda. And Amanda, I'm so proud of you for just getting your BLS card. And Amelia, you have it. So yes, for a pregnant mother, you would not be doing abdominal thrust. The best movement is to go a little bit above their breast line, or where you think their nipples would be. Go a little bit above, knuckle in first. So you make a fist, tuck the thumb of that fist, and you go straight in. So with chest thrust, you don't go up, you go straight in, and you keep doing that until the object is expelled, or like we said with the non-pregnant person, or until they become unresponsive. Once they're unresponsive, scream for help and start CPR, beginning with your chest compressions. 12, a nurse assistant observes that a patient's urine appears red and reports it to the nurse. The nurse explains that this may be hematuria. What does hematuria mean? A, excess protein in the urine, B, blood in the urine, C, pus in the urine, or D, sugar in the urine. And I spent a lot of time teaching you all medical terminology, because if you fail your written test as a CNA, it is normally because you didn't take time to learn prefixes, suffixes, or your terminology. So you have to know these terms so you can answer those questions. Plus, when you're in the field working, it's going to make you a much better caregiver because you're going to understand what the nurses and the doctors are saying, and you're going to understand your patient's history and physical. Okay, so if a patient has hematuria, that means that they have B, they have blood in the urine. And so it can appear pink, it can be red, or kind of like color soda. Soda colored, excuse me. It depends on how much blood there is. If it's just microscopic or really light, the urine can appear pink in color. But it can be caused by urinary tract infections, kidney stones, trauma. Trauma would be from the catheter that we had in place and we remove it. It's irritated the urethra. And so now sometimes when they first start urinating, you would see a peach or a pink colored urine. So healthcare staff should report hematuria promptly because it may indicate a serious underlying condition that requires medical evaluation. 13, a patient's heart monitor shows an abnormal heart rhythm. Which medical term describes this finding? Is it A, apneic, B, hypertension, C, bradycardia, or D, arrhythmia? And if me pronouncing these words helps you to understand the terms, don't forget that when you take your CNA examination, you can request an audio exam. Yes, you can get an earpiece that reads the questions to you. And I usually do not charge more for that, but you need to let your school, your instructor know that you prefer an audio earpiece while you're taking your CNA test. When we say that a patient has an abnormal heart rhythm, we're referring to D, arrhythmia. And I like to think of arrhythmia as the lack of rhythm. So when Nurse Eunice dances, she doesn't have any rhythm. So when you look at this strip as a CNA, it's not about you knowing what rhythm this is. It's about you knowing what regular looks like. So regular would be nice and tight. And so with this strip that's on the screen, you're going to see a QRS complex that's close together. And then you see a wide and bizarre complex. That would be arrhythmia. And so if you see something that doesn't look right on the monitor, go find your nurse. Hey, Eunice, can you come here? I just saw something on this monitor. I'm going to help explain it to you. So an arrhythmia is an abnormal heart rhythm. It means the heart may be too fast, too slow, or with these wide and bizarre beats, it could be irregular. Arrhythmias are often detected using heart monitors or EKG machines. 14, a resident with dementia is yelling and pacing. What is the best de-escalation approach? Is it A, ask the nurse to administer a sedative? B, tell him to calm down? C, use short phrases, calm tone, and offer a quiet space? Or D, apply soft wrist restraints? Ooh, I am enjoying studying with you all. I have missed you all so much. A resident with dementia, they're yelling and pacing. What are you going to do? Looks like someone had put D, apply soft restraints. You can't restrain them because they're yelling. So the answer is not D. That's right, everybody. It is C. You're going to use those calm tones. Ask them what the problem is. So it's C. Residents with dementia may become agitated due to confusion, fear, overstimulation, pain, or unmet needs. The best de-escalation technique is to remain calm, speak in short and simple phrases, and reduce stimulation by offering a quiet and safe space. A calm approach helps reduce anxiety and it prevents the situation from escalating further. As a side note, telling patients or residents to calm down never results in them getting calmer. They actually get worse. So don't tell people to calm down. Let's go to our next question. 15. A resident repeatedly tries to stand without help. The best fall prevention action is it A, move the resident to the nurse's station? B, keep the call light in reach and clear the pathway and ensure non-skid footwear is available? C, dim the room completely? C, dim the room completely? Or D, raise all 4 side rails to prevent him from falling? What is the best fall prevention action? This one's a little tricky. We're not giving him lorazepam. Oh, yes, I missed you all. It's been so busy, Amanda, but I'm happy to be here with you today. All right, so we have D, we have B's. Anybody else? The B's have it, yes. And so actually raising all the side rails is you could be charged with abuse, and we'll talk about it in a moment. So the answer is B. If a resident repeatedly attempts to stand without assistance, the best fall prevention measure or approach is to combine multiple safety interventions. Keeping the call light within reach allows the resident to request help, clearing the path, reducing tripping or hazards, and then activating the bed alarm. So some of your facilities will either have a pad that you can put on the bed, or we can usually allow the first two rails to be up without a doctor's order. But if you put all four rails up and there is no doctor's order for that, that would be considered a restraint, and we're not supposed to restrain our patients. On top of that, whenever you have all four rails up, the patient's behavior has not changed. They still are going to try to get out of the bed. Now they're climbing over the rail to get out of the bed. That's why you're oftentimes going to see, especially in some of your fancier nursing homes or long-term care facilities, the beds go all the way down to the floor and there's a pad next to the bed. So if the patient or resident does fall on the floor, it doesn't result in an injury. So we, the healthcare providers, are what prevents these patients from falling. And it takes multiple steps. We have to get into their room fast if they do call. And if that doesn't work, you can talk to your nurse, and maybe your nurse can get a sitter in the room with that patient. 16, which abbreviation means every 4 hours? Is it A, QID, B, Q4H, C, BID, or D, HS? Which abbreviation means every 4 hours? And if you're enjoying this test, give us a thumbs up, because we're here studying on a Saturday. And it's a beautiful day in Florida. I hope it's beautiful where you are also. All right, revealing the answer in 3, 2, and yes, I see the correct answers. We're torn between A's and C's. I don't see the correct answer yet. There we go. Mary has it. So it is Q4H. Q means every, 4 would be the frequency, and H means hours. So you could see it as Q4 or Q4H. But if you didn't know that, make sure you have pen and paper with you to be writing these things down. And you can always go back and rewatch this video on YouTube. 17, which abbreviation means twice daily? And for those who have our CNA exam prep book, you have abbreviations and terminology and a practice test in the back of the book. So is twice daily, does it mean A, BID, B, TID, C, AC, or D, PRN? And you have to learn this terminology, these abbreviations, because when you're working with nurses and doctors, we don't say, oh, he needs his medicine twice a day. We're not going to say that. We're going to be like, oh, it's ordered. Thank you for saving the video, Amanda. Yes, so when we say that something is twice a day, it is A, BID. So twice a day is BID, and oftentimes it's referring to maybe a dressing change schedule or a medication. As a CNA, some of the stuff will be not necessarily within your scope of practice, but the patient's going to be asking you questions, and it'll be like, hey, how often do I get my dressing changed? And that's just easy for you to go look in the chart and be like, oh, you get it done twice a day, because in the chart it's going to say dressing care BID. 18, which abbreviation means before meals? Is it A, HS, B, PRN, C, AC, or D, PC? I am so proud of you all. Which abbreviation means before meals? I think some of you are looking it up. All right, we'll talk about them. I'll start putting them in the chat. So HS equals hour of sleep or bedtime. So it's not A. What does PRN stand for, everybody? PRN is as needed. That's right, it is C. So it's AC would be before meals. And I'll put the last one in here. PC would be after meals. So oftentimes when you see AC and PC, it's referring to a patient who has diabetes. And we would have orders for their glucometer or their Accu-Checks, AC before meals, PC after meals. And whenever your nurse, if you're allowed, because not every facility allows the CNAs or the PCTs to do the glucometer checks, if you're allowed, you have to get those finger sticks done before the trays come. Otherwise, if the patient starts eating, the food is going to elevate their blood sugar. So when we say that we need Accu-Checks AC, make that your priority. Go in there and get that Accu-Check done before the trays are delivered. 19, which is reporting? A, writing 850% in the record. B, documenting repositioning time. C, recording output on the flow sheet. Or D, telling the charge nurse that a resident has pain, rating a 5 out of 10. Which one is reporting? That's right. Great job, everybody. I'm seeing those answers coming through. And we're streaming on 3 different platforms. So I'm thinking that if you're on TikTok or Facebook, that could be some of the delay. Yes, Amanda and Emilia, reporting is what you verbally say. A, B, and C would be documenting or recording. So when you're reporting, it's verbal. Reporting means verbally communicating important information to the nurse or charge person, especially when there is a change in a resident's condition, such as new chest pain or new pain period, or maybe there's coloration changes with their skin, all of which could indicate a medical emergency. So it must be verbally reported right away. And then once you verbally report it, when you have a moment, you could go and document it. And when you document it, you would put who you told and what you told to that person. And that closes that cycle. 20, which is the best example of objective charting? A, resident was lazy and didn't get up. B, resident walked 20 feet with a walker, required 1 rest break. C, resident seems dramatic. Or D, resident had a bad attitude. And if you're not aware, those residents and patients are feisty. So you got to toughen up a little bit. I know some of you all are sweethearts. You got to toughen up if you're going to work in healthcare, because you got feisty residents and patients, and you also have feisty CNAs, nurses, and doctors. So everybody's feisty. All right. So for 20, the answer is going to be B. Objective would be measurable. You took 30 steps with that resident, so you're able to count that. Objective charting means recording facts that can be observed, measured, or verified without personal opinions or judgment. 21, a resident's blood pressure is 84/48 and they feel faint. The best immediate CNA action while waiting for the nurse would be, is it A, notify maintenance because the BP machine malfunctioned? B, encourage walking to wake up the circulation? C, assist them to lie down safely and wait for further instructions? Or D, assist them to lie down safely and raise the legs if allowed by policy? All right, waiting for a few more responses. Revealing the answer in 3, 2, and hey, Sandra. I see you there, Sandy. All right, so Sandy says C. Do we have any other takers? Revealing the answer now. And for everybody who chose C, I'm so proud of you. It could have been D, but normally we don't allow CNAs to raise the legs without the nurse telling you to do so. Here's the rationale. A blood pressure of 84/48 is very low. We refer to that as hypotension, and it can cause dizziness, fainting, and falls. The CNA's immediate priority is patient safety. So you're waiting for the nurse to come. So you're going to assist the resident to lie down. That's going to help to prevent the fall. Because if you have them sitting up, they can get dizzy. They can still fall to the side and hit the side rail. So get them down. The CNA should then report the abnormal vital signs to the nurse as soon as they enter. And the nurse will decide if the legs need to be elevated, not the CNA, because a patient can have congestive heart failure. They can have other issues, and you raising the legs, yes, it's going to improve circulation, but with them laying flat and their legs up, it can also worsen their breathing problems. So that's why you get that nurse in the room. Let that nurse make the call. 22, a resident's temperature is 102.8 degrees Fahrenheit, and they have chills. What's the first CNA step? Is it A, notify the nurse immediately? B, recheck the temperature and notify the nurse? C, offer a hot bath? Or D, turn the heat up to maximum? If you do D, no one's going to like you. The patient might like you temporarily until they no longer have chills. That is right. You have it. Anytime you have abnormal reading, especially if it's just one abnormal reading, you go ahead and recheck it. You're in the room anyway. It takes a whole 20 seconds. So while you're in the room, you get abnormal reading, go ahead and recheck it, call your nurse, give your nurse both readings. So the answer is going to be B. Confirm and observe. Fever may indicate infection and requires prompt escalation per facility protocol. So this patient has chills and they had an elevated temperature. More than likely they have an infection. 23, a nursing assistant notices that a resident suddenly has a drooping face and is having trouble speaking. Which fast stroke assessment sign should the nursing assistant check next? And so they have facial drooping. What comes after facial drooping? Is it A, check if the resident can lift both arms? B, check the resident's temperature? C, check the resident's blood sugar? Or D, ask the resident to walk across the room? Think of the fast assessment for strokes. F stands for face, and we have already stated that the face was drooping. That's right. Everybody has it. A stands for arms. And the nurse goes, wow, I'm giving you all applause. So the FAST survey is a quick way to recognize signs of a possible stroke. The F stands for face. Ask the person to smile, and you're going to look for facial drooping or asymmetry, meaning that the smile is not even on both sides. A, arms, ask the person to raise both arms, and one arm may drift down. It's not going to raise as high as the other one. S will be speech. Check for slurred or unusual speech. And then T, time. Time is crucial. Report symptoms immediately so that the resident can receive emergency care. So if you're in a hospital or nursing home, you're going to hit that code or that panic button to get your nurse in the room. If you're in home care, you are calling 911 first, and you call that nursing or that staffing agency after 911 has arrived. And I saw someone earlier, Lois had just joined as a at the level of Scrubs and Ambition. I want to thank you all, our channel members. I just uploaded all of these slides today, so you get to have this practice test. Just go to your members portal and you will be able to download these questions so that you can practice with your friends and family. So thank you for your support. If you're not yet a channel member, you can do so by going to our YouTube channel. It's youtube.com/Florida Training, and you're going to see an icon that says join. All right, let's keep going. Question 24. A resident with a feeding tube is lying flat and coughing. What is the most likely cause? Is it A, influenza, B, walking pneumonia, C, aspiration, or D, acid reflux? Feeding tube. So they have a tube in their stomach. They're laying flat and they're coughing. What in the world is happening? First of all, why did you lay them flat with the tube feeding going? We don't do that. And so, what is happening? What's the cause of them coughing while they're lying flat? Everybody has it. Yes, it is aspiration. So, those fluids have traveled up via the esophagus. And now when we sit them up, those fluids, that tube feeding, can go down into their lungs. So if you have to take care of somebody who has a tube feeding and you have to lay them flat, you have to pause the tube feeding first. Make sure your facility allows you to do so. Otherwise, your patient can aspirate. Here's the rationale for C. A resident with a tube feeding should not be laying flat during feedings because this increases the risk of aspiration. Aspiration occurs when food, fluid, or stomach contents enters the airway or lungs, which can cause coughing, choking, or breathing difficulty. Elevating the head, usually they're going to have an order. And someone who has a tracheostomy also, they're going to have an order that says keep the head of the bed at 30 to 45 degrees at all times. And so only time we would lower it is, of course, if the patient is not having any symptoms and if the nurse is there also. But if they have a tube feeding going, you have to pause it, not stop it. You have to pause it, and then you would resume the feeding once the person is back upright. 25, for a resident with urinary incontinence. Oh, thank you so much, Amaray. I will get the information to you. Thank you for inquiring about how to become a member. How can I see my, you would go into the post section. And if not, let me put my email address in here. Just email me later and I can send you a screenshot. Okay, I just put it in there. All right, so for a resident with urinary incontinence, the best skin protection is which of the following? Is it A, talcum powder, B, barrier cream, C, petroleum jelly, or D, scrub the skin vigorously or aggressively? Your patient has urinary incontinence. How do you protect the skin? I can't believe that none of you all wanted to put petroleum jelly because that would have been absolutely wrong. So yes, it's going to be B. It's going to be barrier cream. We don't use petroleum jelly because it doesn't allow the skin to breathe. So barrier cream, it protects from the moisture while allowing air to flow through so the skin can be protected but remain somewhat dry. I hope that makes sense. So we're going to make sure we clean the area first. After we clean it, we're going to dry it, and then we provide our barrier cream in order to protect it against the damage from the moisture. And then Anne-Marie, I gave you the email address. It's in the chat. So just go up a few slides because I can't help you access the portal while I'm doing a live. All right, so 26, a resident with heart failure develops swelling in both legs and ankles. What is the medical term for this condition? Is it A, cyanosis, B, thrombosis, C, hematuria, or D, edema? A resident with heart failure has swelling in both legs. What is the medical term for that? Looks like we have some B's. We have thrombosis. We have a lot of B's. I'm surprised. You're going all the way to 100. That's right, Sandy and Gazelle and Glitter Pop Diaries. That's right, it is D. The fact that they have the swelling in both legs and ankles, that's a sign of heart failure. If it was just one leg, that would be a thrombosis. That would be B. But it's bilateral, you all. So 26, the answer is D. Edema is the medical term for swelling caused by excess fluid in the tissues. In residents with heart failure, the heart cannot pump blood effectively, which allows fluid to build up in the lower extremities, such as the legs, the ankles, and the feet. So again, that's usually bilateral, both legs. If it's a clot or a thrombosis, that'll just usually be one extremity. 27, a comatose patient needs oral care. What is the best approach? A, use a large amount of water. B, provide hard candy to stimulate saliva. C, use suction/oral swabs and sit the patient upright. D, use suction/oral swabs and keep the head turned to the side. A comatose patient needs oral care. We still have to provide care to someone's mouth, even if they are unresponsive, because the mouth is a pathway. If those germs get into the mouth and we don't clean their mouth, it's going to go down to their lungs, to their stomach. And if it unfortunately gets into their bloodstream, then that infection, those germs can travel to the heart. So we have to provide mouth care on all residents, including those or patients, and including those who are unresponsive. When you have somebody who's unconscious or unresponsive, that usually means they don't have a gag reflex. So if you sit them upright and put fluids in their mouth, they're going to aspirate. So the answer is not C. Oh no, Simone, I'm so sorry to hear that. The answer is D. Simone, you're going to have it next time, dear. Missing it by 1 point, you were so close, and hopefully you get to retake your test again soon. For CNAs, whenever they don't pass their exam, they have to wait 30 days. You're 30 days. You're almost there. You're 29 days away from being a PCT. It's going to happen. Thank you for studying with us. All right, so everybody who chose D, you have it. And I have an illustration there. This person has a padded tongue blade. You may not have all that in your facility, but the tongue blade is how we determine whether or not a patient has a gag reflex. This patient's unconscious. You turn them to the side. That way, if the fluids don't all come out, they would actually pool into the cheek area. You can use your suction in order to remove any excess fluids. Whenever someone's unconscious, to provide mouth care, you turn them to their side. Rationale: a comatose patient cannot swallow or protect their airway, which increases the risk of aspiration. Oral care should be provided using oral swabs and suction if available, while keeping the patient's head turned to the side. This helps prevent fluids from entering the airway and maintains oral hygiene and infection prevention. 28. A resident with anemia is most likely to show which symptom? Is it A, pale skin and fatigue, B, high fever, C, severe swelling, or D, persistent coughing? You're welcome, Simone. I can't wait to hear back from you. You're going to do well. All right. If a patient has anemia, how do you expect for them to present? Because you're looking at this chart, you see the admission diagnosis. When you look at some of these diagnoses, you have to be expecting your patients to have certain symptoms, even if they don't have them. If they don't have them now, beautiful, fine. But you're the person who's in the room the most. So if these symptoms start to occur, you're going to be like, oh, they're having a worsening of their anemia. So when someone is anemic, there is not enough blood, and blood carries oxygen. So if their oxygen levels are low, they're going to be fatigued easily, they're going to be short of breath, and that can cause them to be dizzy, and their skin would be pale. So yes, the answer is A. 29. A resident with limited mobility is at the highest risk for pressure injuries at which location? Is it A, forehead, B, heels, C, palms, or D, elbows only? A resident with limited mobility is at greatest risk for pressure injuries at which of the locations listed on the screen? That's right. It is going to be the heels. The sacrum, which wasn't listed, would be the most common source, but the sacrum and the heels, any place where bone is touching bone or bone is touching bedding, is called a bony prominence. So if you have a patient who's been on one side for too long, that hip that they're laying on, and then the outer aspect of their feet, their elbows, they can start getting redness on those bones. So that's why we have you reposition and turn your patients every 2 hours. And to prevent those inner knees and those inner toes from touching, we would also put a pillow between their legs. 30. When repositioning, the best practice is to A, pull the resident up by the arms, B, pull on arms and ask the resident to push up with his feet, C, use a draw sheet, or D, lift by clothing? I have my interns this week, and they're all teenagers. I think I'm going to do some CNA skills with them and have them try to lift me up in the bed and see if they can get it done. See if my teen assistants would do well as CNAs. What do you think? All right, I don't see the correct answer. Yes, and I now see the correct answer. Yes, it's so many of you all now. Yes. So the answer is C. We're not going to be pulling them up by their body parts. Amanda, we look forward to seeing you again, dear. So yes, it's going to be C. We're going to have to use that draw sheet. So just turn them, put the sheet under them, and now you would lift the sheet with the patient on top of it. That's how you prevent injuries. We tried to pull them using their joints. So whenever you use a draw sheet, the answer is C, because it reduces shear and friction and skin tears. 31, resident has very little urine output. Which term describes this condition? Is it A, polyuria, B, dysuria, C, hematuria, or D, oliguria? You have to learn your prefixes, ladies and gentlemen. So we know the URIA refers to urine, but what is that prefix, the term that comes before the word that changes the word? Which one is the correct response for little urine output? And we did hematuria earlier, so you all should know what hematuria means. Gazelle and Emilia, I know you can't see my face over here, but I am smiling. Yes, it's oliguria. Yes. All right, dear. Come back and watch the video, and good luck on your test on Monday. We're praying for you, Mary. All right, great job, team. 32, this is a long one. A CNA is assisting a resident who is taking a blood thinner medication. While helping the resident transfer from the bed to a wheelchair, the resident accidentally bumps their arm on the bed rail and receives a small skin tear that begins to bleed. What is the most appropriate action for the CNA? A, apply pressure for about 2 minutes and then cover the area with a bandage. B, clean the area immediately with alcohol and leave it open to air. C, apply firm pressure to the area for several minutes until the bleeding stops. D, elevate the arm briefly and resume the transfer. This one's tricky. I'm going to give you a few more seconds to read that again. Your patient's arm is bleeding. They have a skin tear. All right, revealing the answer in 3, 2, and yes, it is C. I see you all now. It is C. So you're not going to apply pressure for 2 minutes and then apply a bandage. That's why it was an A, because the person who's on a blood thinner, you apply pressure until the bleeding stops. That can be longer than 2 minutes. And you wouldn't want to bandage it without the nurse being made aware, because we may have to put neosporin or something on it so it doesn't get infected. And you're never going to put alcohol on a patient's open wound. So here's the rest of the rationale for C. Residents taking blood thinners or anticoagulants, such as warfarin or heparin, bleed more easily and may take longer to clot. When minor bleeding occurs, the CNA should apply firm but direct pressure for several minutes until it stops. Maintaining pressure allows the body enough time to form a clot. Quickly stopping pressure or ignoring the bleeding can lead to prolonged bleeding or complications. And then I saw somebody whose test was postponed due to the storm. Well, I hope that they reschedule that soon. And now it just gives you more time to study, Kurdala. And preferably you're going to be successful when you go back into that testing site. Our next response for 33, our resident's oxygen tubing creates a loop on the floor. What's the best action? A, remove the tubing extension. B, place it under the rug. C, cut the tubing shorter. Or D, tape it down neatly or reposition to remove the tripping hazard. And because this one's so easy, I'm revealing the response in 3, 2, and we know we're not going to cut anything. We're not going to hide it under a rug. So it's going to be D. We're going to like tape it. Those loops can become a fall hazard. So loops and oxygen tubing on the floor create a fall hazard for both the residents and the staff. We don't want to fall either. The safest action is to remove the tripping hazard by taping the tubing securely to the floor or reposition it so that it does not create loops or obstacles. This helps maintain both oxygen delivery and environmental safety. You're rarely going to see this in a facility. You'd oftentimes see this in someone's home where they have oxygen tubing that stretches from the front door all the way back to their bedroom. 34. What is a sign of peripheral vascular disease, also referred to as PVD? A, one swollen calf. B, bilateral leg pain when walking. C, severe headache. Or D, slurred speech. When we say a patient has PVD, what area of their body are we referring to that has vascular disease? Yep, you're learning new terms today. You are. So when someone has PVD, their leg is going to look like this. They could be discolored. They can be swollen. It's the color is not going to be uniform with the rest of the body. Sometimes their legs get really shiny, and it's going to be both legs. It's not just going to be one leg. So the answer is B. PVD often causes poor circulation, leading to pain in the legs during activity, and we call that claudication. So they're going to really say, my legs are heavy and it hurts when I walk. Of course, your nurse should be assessing. If she checked those pulses, the pedal pulses are probably weaker than normal, and that patient's legs will be swollen. And they'd be more prone to injury and sores because they have decreased circulation. So if they get injured, they don't feel it. 35, a resident with airborne precautions should have which room placement? Is it A, semi-private room, B, a room with an open door, C, a negative pressure room, or D, the room closest to the nurse's station only? A resident with airborne precautions, which would be different than droplet. Remember, for droplet, the particles were heavy, they didn't travel far. Airborne, when this patient sneezes or coughs, it just travels all over the place. So we have to make sure that they have a special type of room. And what room would that be? That's right, Sias Rose. It would be a negative pressure room. And so the answer is C, and this is how a negative pressure room works. They have to have their own private bathroom. They have what we call like an ante room. That is where the nurses and the CNAs, they go in and they gown and they glove up. So it's like layers to this room. And instead of the air, when you open the door to enter the residence room, instead of the air going into the hall, that room has a separate HEPA filter, and that air is sent outside via pumps away from the hospital. So when you open the door, that contaminated air doesn't travel into the hall. So for people who are on airborne precautions, such as somebody who has tuberculosis, they're going to be in the negative pressure room. 36, a resident is on a neutropenic precaution. What's the best action? A, screen visitors for illness. B, bring fresh flowers to cheer them up. C, encourage raw fruits, veggies without washing them. D, allow anyone to visit freely. You have to understand what neutropenic precautions are. And if you don't know, write it down. You have to improve your muscle memory, and writing helps you do that. So when the patient is on neutropenic precautions, that means that is reverse isolation. Their immune system is so weak. Let's say somebody who has cancer, who's receiving chemotherapy, until we, the healthcare staff and their family members, bring germs to them that make them sick. So the best way to help protect someone who's on neutropenic precautions is to make sure that we do we have to screen the visitors, and we have to gown and glove up and put on masks so that we don't take those hospital germs into their rooms. So neutropenic precautions are used for patients with a very low white count. The white blood cells are what fight infections. So their immune systems are weakened and they have an increased risk of infection. Visitors who are sick or recently exposed to illness should not visit. They cannot have fresh fruits. They cannot have fresh flowers. They can't have any of that. So screening visitors for signs of infection and also keeping away those things that can bring infections into the room. That's how we help to keep our residents safe. 37. A resident with tremors and slow movement most likely has which condition? Is it dementia, stroke, pneumonia, or Parkinson's disease? They have tremors and slow movement. And some of you all have been here for this entire test. You've been here for over an hour now, so thank you. We're going all the way to question 100. Whenever someone has tremors and slow movement, they have D, Parkinson's disease. Parkinson's disease is a neurological disorder that affects movement. Common symptoms include tremors, slow movement, we call that bradykinesia, muscle stiffness, and balance problems. These symptoms develop gradually and often worsen over time. So someone can have dementia without Parkinson's, and someone can have Parkinson's without dementia. So you don't have to speak to them, slowly. Initially, it's like, okay, they may not have memory loss is what I'm trying to get to. So make sure you read your patient's chart so you're not treating a person with Parkinson's as if they're forgetful. 38, a resident's roommate says he has HIV, be careful. What is the best response? A, confirm and discuss the safety. B, ask the roommate about the source of the information. C, explain that you can't discuss another resident's health information. D, ask for more details. Right. I'm seeing some correct responses coming through, so I'll give you about a few more moments to answer. That's right. We're going to protect their confidentiality. So we would not confirm nor deny. We're going to have to just change the topic. We cannot discuss that. I'm not going to be able to discuss his care with you. So the answer is C. Confidentiality is required. Residents' medical conditions, including HIV statuses, are confidential health information that must be protected under privacy laws such as HIPAA. Staff must not confirm, deny, or discuss another resident's health condition with others. The appropriate response is to maintain confidentiality and explain that you cannot discuss another resident's medical information. 39. Which action best prevents catheter-associated infection? Is it A, keep the drainage bag above the bladder level? B, keep the drainage bag below the bladder level? C, place the bag on the bed? Or D, milk tubing every hour routinely? Revealing the answer in 3, 2, and you have it. It is B. We're always going to keep that bag lower than the bladder to prevent backflow. If you allow that old urine to travel back up into the bladder, of course, you're going to give the patient a UTI. 40. A resident with a Foley complains of bladder pressure. What should the CNA do first? A, check the physician's order. B, document immediately. C, assess the abdominal area. D, check to see if the tubing is kinked or if the bag needs to be emptied. There is a typo there. It shouldn't say bad, it should say bag. Right, waiting for a few more responses. So when someone has an indwelling catheter and they start complaining of bladder pressure, yes, that's right. You want to check to see if the tubing is kinked. So the answer is D. If a resident with a Foley or an indwelling catheter reports bladder pressure, the first step for a CNA is to check for simple mechanical problems such as kinked tubing. Is the drainage bag positioned above the bladder? Because remember, it's not supposed to be above. It should be below. Is the tubing compressed under the patient? Sometimes the leg, especially if the patient's obese, the weight of their leg could compress the tubing, which would obstruct the urine flow. And then something else that you all may forget is that you're supposed to empty that bag at least once per shift and or when it's half full. So if that bag is full, no new urine can drop into the bag, and that means that that pressure is going to build up in their bladder. So if you have done all those troubleshooting steps and that patient's is still complaining of bladder pain or distension, that's when you would get your nurse into the room. But you do those basic checks first, and that only takes about 2 minutes for you to go through. 41, a resident's urine output is very low this shift. The best response by the CNA is to A, accurately measure totals and observe for dehydration signs. B, throw away the record because it's too much. It's not much. C, force fluids. Or D, estimate output without measuring. So your patient had very little urine on your shift. What should you do? That's right. You're going to document it. You're going to measure it accurately. You're going to document it, and you're going to let your nurse be made aware. The answer is A. Do not force fluids without the nurse telling you to do so, because we have certain patients, such as those who have renal or kidney disease, or those who have congestive heart failure, where if you give them too much fluid, their kidneys and their heart can't tolerate it. So if your patient isn't producing urine, go and speak to your nurse because they may not be producing a whole bunch of urine because they could be on a fluid restriction due to their other health issues. 42, what is a sign of urinary retention? Is it A, frequent urination, B, painful urination, C, bladder fullness and little urine output, or D, blood in urine? Urinary retention, what is a sign? The answer is C. So bladder retention occurs when the bladder cannot empty properly, causing pressure and distension. And when you look at the screen, the caregiver has a handheld device, and that's referred to as a bladder scanner. So if a patient starts complaining of pressure and they haven't urinated, as a nurse, I'm going to call the doctor to notify the doctor, and more than likely, we're going to have to use a bladder scanner. And in a lot of your facilities, the CNAs are taught how to use them. So a bladder scanner is a non-invasive portable ultrasound device used to measure bladder volume and post-void residuals. And so as you scan, it's going to read, and then it's going to give a printout, and it's going to let us know how much urine is in that patient's bladder. And based upon that, the doctor will then write an order for a catheter or some other orders for medications. But that's how we treat urinary retention. 43, a resident repeatedly tries to hit staff during care. The best safety action is to A, continue care alone, B, threaten consequences, C, pause care, ensure your exit path, and use a team approach per policy, or D, block the doorway. And these patients are getting more and more violent. So I need for you to make sure you're always protecting yourself. So that is right. C, you can pause care. Do not put yourself in harm's way. If a resident becomes physically aggressive, the priority is staff and resident safety. But notice who came first, staff. If they're in a room with another resident, get that resident to safety. The safest action is to pause care, make sure you have a clear exit path, and don't be backed up in the room with someone who is violent. You have to make sure, as we say, read the room. You're going to let someone else know when you go into that room, and your back should always be towards the exit, towards the door. And if necessary, you do not go in that room alone. You use a team approach. Now, the next image may be disturbing to some people, but this is an image of Nurse Lalama, and she was attacked by the gentleman in the photo. He was being held under a Baker Act. So that means that he had a mental health hold. And while she was in the room providing care to him, he jumped off the bed and just started pounding her. She was hospitalized for over a month, and that did not include her rehab care. So it looks like she ended up with a tracheostomy, which has since been reversed. That tube that she has in her nose, that's how she was receiving her feeding. They thought that she was going to lose her eyesight. And so we do have a large problem with people who are now abusing healthcare workers. And so do not do something, do not work at a place where you feel as if you're going to be violated, because I'm sorry, violence is not a part of your job. And so just make sure you stay safe. And I know that she had been a nurse for a while. She never would have thought that somebody would jump off of a bed as small as she is and jump right on top of her and start beating her in the head. But this man did so. 44, a home care resident in a queen size bed without head control. So this is an old fashioned bed that doesn't move up and down. This patient has thick secretions and gurgling sounds. What is the best position for this patient? Is it A, flat, B, prone, C, Trendelenburg, or D, side lying with the head turned? Resident is in a queen size bed that doesn't go up and down, but they have thick secretions and gurgling sounds. What's the best position for them? That is right. It is C. And Shella, you are so welcome, dear. Oh, I said that correctly. I said C. It is D. So it's going to be the sideline position. You can also try to elevate their head on pillows, but until you can get enough pillows in place, turn them to the side. If a resident has thick secretions and gurgling sounds, it may indicate that fluids or mucus are collecting in the airway, increasing the risk of aspiration or airway obstruction. Placing a resident in a sideline position with the head turned allows secretions to drain out the mouth instead of pulling in the throat, helping to clear the airway. Now, this is not a regular bed in the hospital. If it was a regular bed in the hospital, you could, of course, raise it up. I'm sure you had suction equipment. But when you're taking care of patients in some of the I'll say smaller nursing homes or facilities, they don't always have the semi-automatic or fully automatic beds. So while you're waiting for that nurse to come, turn a resident to the side. That will help prevent aspiration. 45, what is a sign of urinary incontinence? Is it A, wet underwear, B, blood in the urine, C, pain during urination, or D, no urine output? Urinary incontinence. All right, I'm waiting for some answers. Yeah, you have to know terminology if you're going to pass your CNA examination. So when someone is incontinent, they cannot control their urine or their bladder. So they can have urinary incontinence, they can have fecal incontinence. And if someone can't control their urine, that means that they are going to be wet. So if you chose A, you have it. Incontinence is the loss of bladder control resulting in unexpected leakage. The way that you prevent incontinence as a CNA is to take your resident or your patient to the bathroom more frequently. 46, which term refers to swelling caused by excess fluid in the tissues? Is it A, dyspnea? Is it B, apnea, C, tachycardia, or D, edema? Which term refers to swelling caused by excess fluid in the tissues? And we already covered this one. It is D, edema. As a CNA, something you could do once the nurse is giving you permission, you can elevate the legs on pillows, or if their arms are edematous, you can elevate the arms also, but check with the nurse first, because for certain conditions, we don't always elevate the legs. It just depends on the cause of the edema. 47, which disease is caused by blood clots blocking blood flow in the brain? A, stroke, B, seizure disorder, C, Parkinson's disease, or D, dementia? I hope I say it right. Omicron? Yes, great job. love you too, Juliet. All right, everybody. So for 47, the answer is A. Blood clots blocking the brain. They're going to have a stroke. That's right, Mary and Evelyn and Benjamin. Benjamin, thank you so much for the photo. I love seeing you all. I've met quite a few of you, but Benjamin sent us a photo, so I appreciate it. And his wonderful story, his testimony. So the answer is A. A stroke occurs when blood flow to part of the brain is interrupted, often due to a blood clot blocking a blood vessel. This type is called an ischemic stroke. When brain cells do not receive oxygen and nutrients, they begin to die within minutes, making it a medical emergency. And so when someone has a stroke, they would have hemiparesis, which means that half of their body could be weak, or they can also end up paralyzed. So in this case, his body, half of it's weak. He can still swing that leg, but that hand is kind of curved in, and we refer to that as being contracted. But he's still able to move on his right side. And then Juliet, I rarely talk to anyone, but you're welcome to email. And I'm going to put our email address in. As you know, I stay pretty busy, but email, and then my office manager can let me know if it's something that I need to address. 48, what is a sign that a resident needs diet modification? Is it A, elevated mood, B, high blood pressure, C, difficulty chewing or swallowing, or D, back pain? You're in the room with this resident more than a nurse, more than a doctor. And so what you report matters. How would you know if a patient needs their diet modified? That's right. They're having difficulty chewing and swallowing. Aletha, you got this. Congratulations in advance. Yes, you're going to pass your test. And you're studying this weekend. You're studying hard. So I am so proud of you. Everybody who put C, you have it. Give yourself applause. Residents who have difficulty chewing or swallowing may require diet modification. So they start off on a regular diet, then they go to a soft diet. And then if the soft diet doesn't work, they have a mechanical soft diet where the food is like really chopped up. Then they can go to a parade diet. So yes, the nurse is watching, but you're in their feet in the resident. And so you're going to know if that resident has their dentures. If the resident doesn't have their dentures in, you need to let your nurse know so we can figure out what to do about the dentures, number one. Then number two, get their diet changed. And so that is how we work together, because modifying their diet helps to prevent choking and aspiration, and it makes them getting their nutrition easier. 49, a CNA is assigned to care for a resident with C. diff infection who is on contact isolation. Before entering the room to assist with toileting, which PPE should the CNA wear? A, surgical mask only, B, gloves and gown, C, gloves and face shield, or D, N95 respirator mask only. And here locally, depending on where you're working, you're going to have 10 to 15 patients in the hospital, whether it's day shift or night shift. Night shift, you'll have closer to 15. If you're working in a nursing home, sometimes you have 30 patients. And so you're going to learn pretty quickly what to do, what not to do. But in the interim, I'm hoping that I'm, preparing you so that you understand when your patient has C. diff, that you're going to be doing B. You're going to be gowning and gloving up because you don't want to spread that infection throughout the facility. And you definitely don't want to contaminate your uniform, because doing so means that when you get home, you contaminate your house too. 50, a resident's respirations are 28 per minute. They're shallow and this resident looks anxious. What is your first response? A, ask them to calm down while you're waiting for the nurse. B, sit them upright and stay with them while notifying the nurse. C, offer a snack. D, encourage them to walk it off. Miss Nancy, you look anxious. Let's go for a walk. Not saying that that's not going to work. It's just not the safest for a patient who's breathing 28 breaths per minute. And so what's going to be safe is for you to sit them up. It's going to be B. Let's sit up and let's try to do some controlled breathing, Miss Nancy. The answer is B. Here's your rationale. Tachypnea and distress are urgent. She's breathing 28 breaths per minute, which is faster than normal. She's not getting enough oxygen. So positioning will help with her breathing. Again, asking a resident to calm down is not the best response, as it does not address the resident's immediate breathing needs. So instead, say, can you breathe through your nose and out through your mouth? Try to get them to breathe a little bit slower by telling them how to breathe. When someone's anxious, they sometimes forget. 51. Which is the best example of scope appropriate observation for a CNA? Can a CNA do A, diagnose pneumonia, B, adjust oxygen flow, C, note that the lungs sound wet bilaterally and that the patient has a productive cough, or D, note that the patient has a new productive cough with green sputum? Which of these would be something that a CNA would say or document? Some of you are in nursing school and you know so much, but you cannot go beyond your scope of practice. Your certification as a nursing assistant means that you are an assistant to the nurse. You are not the nurse. So the nurse would auscultate. The nurse would do C. My CNA would do D. So the CNAs observe, tell me what you saw, tell me what you smelled. You observe and you report the factual signs. They do not diagnose, listen to lung sounds, or change treatments. 52, while taking vital signs, a CNA records a blood pressure of 88 over 52 millimeters of mercury for a patient who normally has readings around 120 over 80. What should the CNA do next? And then, Regina, it just depends on which source you're watching from, because I'm on question 52, but everyone's getting in at different times. So I'm on question 52, but I think others are a few slides behind. So your patient whose blood pressure is normally 120 over 80, their blood pressure is now 88 over 52. What do you do next? A, document the reading and continue the assessment or the assignment. B, notify the nurse immediately. C, recheck the blood pressure to confirm accuracy. Or D, wait until the next scheduled vital sign check. And then Benjamin, I do see your message. Yes, sir. All right, we have a lot of B's for 52. Anything else? Anything else? I'm gonna tell you what happened once. My tech came out and said, our patient's blood pressure is low. And I go into the room and the patient's laying on their side, sleeping comfortably. And the arm that has the blood pressure cuff is the one that's up top. So the arm that's up top, the one that hasn't had blood flow in 2 hours, is the arm that the CNA or the PCT chose to take the blood pressure on. And your blood pressure cuff has an artery indicator. The artery indicator was on the elbow. So I'm rushing to the room, but I'm smart enough to recheck after my CNAs and my PCTs because this patient's blood pressure wasn't low. The cuff wasn't properly positioned and the arm had been in the air for 2 hours. So I need for you to recheck the blood pressure. It's going to be C. If it's normally 120 over 80 and now it's 88 over 52, maybe you did something wrong. It doesn't take long to recheck. It takes about 15 to 20 seconds. So just pause, do the recheck, and then if it's still abnormal, notify your nurse. 53, a resident's dentures are loose and they keep coughing during their meals. What should you do? A, continue feeding them fast. B, remove the dentures and allow the resident to eat without them. C, stop the feeding and keep them upright. Or D, offer thin liquids. Make sure I didn't miss any comments here. All right. I didn't miss any comments. You are going to stop feeding them. If someone's coughing while you're feeding them and their dentures aren't fitting, number one, dentures need to come out, but don't keep feeding them because they're coughing for a reason. They're aspirating. So C is the answer. This patient is an aspiration risk. Stop feeding them. Make sure they're sitting up. Get your nurse in the room. They're probably going to need a swallowing evaluation, and they're going to be NPO until we can figure out what's going on and or until we can modify their diet. 54, a resident on aspiration precautions should be positioned how? Is it A, supine, B, Fowler's, C, Trendelenburg, or D, prone? Do you understand your medical terminology as far as positioning is concerned? What is supine versus Fowler's versus Trendelenburg versus prone? And look like our top fans for today. Gloria, I think it's Glory Fire, is number one with 150 points on YouTube. Mary Kanyako is number two, and Zilma is number three. But Curdell and Vivian and Emilia, you all are tied with Zilma. So thank you all for participating. I'm looking at your points now. Everybody who chose B, Fowler's, absolutely. So when you think of supine, take the U out. They're laying on their spine. You would not allow anybody to lie on their spine, lie flat when they're eating. Trendelenburg is when you place the feet higher than the head. Of course, they cannot eat if they're upside down. And then prone is when they're flat on their stomach. None of your patients should be flat on their stomach unless they're in the ICU. They can't be flat on their stomach because we're supposed to be watching their chest rise and fall. So prone is the position that your patients are least likely going to be in unless they're closely monitored. Whenever your patient's eating, you want them in the high Fowler's position. So that's what's illustrated here in this image. And that is what's going to best reduce those aspiration risk. 55, a resident has a wet cough and fever. The most important CNA contribution is to A, provide accurate vital signs and reserve the breathing effort. B, decide the antibiotic. C, interpret the chest x-ray. Or D, increase the oxygen. And you all are so smart. You're not going to do anything outside your scope of practice. So you know you're going to do A. You're going to document those accurate vital signs and then note whatever observations. Let your nurse be made aware. We have a lot of you who've taken our online CNA courses, and so we want to thank you all for registering for our online CNA course. In the state of Florida, you can challenge the CNA test, but for those who are not in Florida, you also inquired, you want more study materials. And so our online CNA exam prep course is just that. You do not have to be a Florida resident. It has embedded practice tests. It has so many course modules. It gives you way more information than you need in order to pass your test. But the fee is $29.99 per month. You can start and or cancel at any time. And if you're interested in joining our online community, you can do so by going to our website, which is fltraining.com, and just looking for the online CNA exam prep course. For those who are willing to travel to Florida, though, we do have our in-person CNA course. And so we either have a 4-day course in the morning, a course that runs over 4 evenings, and we also have our weekend courses. Regardless of the course that you choose, it's $225. The state fee in Florida is an additional $155. So I like to look at it as for less than $500 in Florida, you can become certified, but you must work in Florida. So if you're coming from another state or another country, this program isn't best for you because, again, you have to take your test in Florida and work in Florida at some point. But you can find information about either of our CNA classes, whether it's the online class or the in-person class, by going to our website, fltraining.com. And let us continue. 56, a resident with diabetes has a small foot ulcer. As a CNA, what would be the best option? Would it be A, pop it? B, allow the resident to wear slides or flip-flops to reduce the pressure? C, soak the foot in hot water? Or D, keep both feet clean and dry? A resident with diabetes has a small foot blister. Hey, Rochelle. We've been hanging out for an hour now, so we've been studying for a while. We're going all the way to question 100. RM, you have it. May Carly, you have it. So yes, it's D. Our diabetic patients should not be wearing flip-flops. So what we're going to do is D. We're going to keep the feet clean and dry because that's going to help prevent infection and protect the skin. And any foot injury in a diabetic patient should be observed and reported to the nurse for further evaluation. And as I just stated, they should not be wearing flip-flops. They have to protect their feet, so they should have on closed-toe shoes. And that's going to prevent injury. As a CNA, when you're giving your bath, you are looking at your patient's body, including their feet, including their heels, because you're the one who's going to detect a change before a nurse will. And Rachel, you can always look at it later. All right, 57. For seizure safety, what should a CNA do? Would you place something in the person who's having a seizure's mouth? Would you move hazards away and protect their head? Would you hold the resident down to prevent injury? Or would you force water after the seizure? So your patient is having involuntary movements. They could be thrashing, that's a grand mal seizure, or it could just be they're staring off in space and maybe their pinky's moving, but they're not responding to you. They're just staring. That would be petit mal. That's right. We're going to move the hazards out the way. It's going to be B. During the seizure, the CNA's priority is preventing injury. You'll see us padding the side rails, putting pillows and pads there. So if the patient already has had a seizure, part of the seizure precaution protocol is to keep those side rails padded. So if you stay ready, you don't have to get ready. That would be a CNA's role, okay? But let's say it's this person's first seizure. There's no padding. Let's prevent them from hurting themselves. They shouldn't be hitting the side rails. Let's put some pillows and some pads there. Let them have their seizure. Unless they're vomiting, that's going to be the only time you hold them on their side. So the CNA should move nearby objects or hazards away, gently protect the resident's head, for example, with a pillow or a folded towel, and allow the seizure to run its course. Document the time the seizure started. So there's always clocks in the room. You have your watch on your wrist. The CNA should stay with the resident and observe the seizure so the information can be reported to the nurse. Nothing should be placed in a person's mouth during the seizure, as this can cause choking, broken teeth, or an obstructed airway. 58. After the seizure ends, what's the best position for your patient? Is it A, side lying, B, sitting up, C, flat on their back, D, prone, face down, or E, any way the patient prefers? Right. So after the seizure, they can be confused and they are also usually pretty sleepy. And so you are going to be the person who protects them. So even if they want to sit up, you're not going to let them sit up. That nurse will, assist you to sit them up if that nurse decides. You're going to have them in a sideline position. That's the recovery position. So the answer is A. After a seizure ends, the resident should be placed in a recovery position if no injury is suspected. This position helps to keep the airway open and allows saliva and vomit to drain out of the mouth, reducing the risk of choking or aspiration. 59. A resident's skin is red over the sacrum and does not blanch. That means the redness doesn't go away. What is the best CNA action? A, massage the area vigorously. B, apply a heating pad. C, offload pressure and reposition. D, ignore the redness because redness is normal. Right, revealing the answer in 3, 2, and yes, it is C. We are offloading. And so whether it's a singular pillow, whether it's a wedge, whatever you can find, get that patient off of their back or whatever area is having evidence of some type of pressure injury. Redness over the sacrum that does not blanch when pressed may indicate the early stage of a pressure injury. The best action for the CNA is to remove the pressure from the area by repositioning the resident and keeping the pressure off the affected site. This helps restore circulation and prevents the skin breakdown from worsening. Evidence-based research says that we should not be massaging reddened areas. So especially if we think it's a pressure sore, that's going to cause the pressure sore to worsen. And then you don't want to apply heat because that's going to increase the blood flow there. But if it's an open wound and you're increasing blood flow there, you could be making things worse. So that's why we don't massage or apply heat to pressure injuries. 60. A CNA is caring for a resident who has had several loose stools during the shift. The CNA must document the findings in the resident's chart. Which injury is most appropriate and professional? A, resident had diarrhea all day. B, code brown cleaned at 1000, 1200, 1400, and 1700. C, gross stool. Or D, 3 loose stools noted between 0900 and 1200, brown in color with strong odor, perineal care provided, and barrier cream applied. Well, that's a no-brainer. Of course it's D. D sounds way more professional. D sounds like you know what you're doing. And so when you're documenting, yes, you want to document the date, the time, the frequency, the characteristics, and also the care that you provided. That would be objective documentation. 61. A resident with dementia repeatedly asks when her daughter is coming to visit, even though she was told earlier that the visit is tomorrow. What is the best response by the CNA? A, I already told you that she's coming tomorrow. B, you need to remember what I told you earlier. C, your daughter is coming tomorrow. Let's look at some pictures together while we wait. D, ignore the question and continue working. So your patients with dementia, they have short-term memory loss. Sometimes they forget that they ate. They're going to be telling you they're hungry again. It's like, Miss Lucas, we just fed you. So the best response for this one is not to antagonize her. You're going to do C. You're going to remind her again, your daughter's coming tomorrow. Let's look at some photos. As the CNA, you should respond calmly, repeat the information, and redirect the resident to another activity to reduce anxiety and frustration. 62. Which isolation is correct for scabies? Would it be A, droplet, B, contact, C, airborne, or D, neutropenic? Just looking at that image makes me want to scratch. You wait until your first patients have scabies and head lice. Yeah. All right, so your patient has scabies. What type of isolation would that be? It is going to be B, contact. That's right, RM and Amelia. You're going to gown and glove up. And I promise, even though nothing's on you, you're going to feel all day like something's on you, especially if you see a bed bug. So scabies spread through prolonged skin contact and contaminated linens and clothing. So if you suspect that your patient has head lice, scabies, bed bugs, you're going to bag up everything they came to your facility with, double bag it, call a family member to come get it and take it out. So your facility will have their established policies, but oftentimes they bring those germs in with them, those bugs in with them, and they're also in their clothing and their bedding. So be careful. 63. Now, measles is different from scabies. So 63, which isolation is correct for measles? Is it A, contact, B, droplet, C, airborne, or D, standard only? And standard means you treat them like you treat anybody else, just gloves and good hand hygiene. Giving you a few more seconds. I know this one's hard. For measles, everybody, measles is actually spread in the air, so it's going to be C. Measles is highly contagious. It's a viral illness that spreads through airborne particles when an infected person coughs or sneezes. Those particles can remain suspended in the air and travel long distances. Because of this, patients with measles require airborne isolation, and that means they must be in what type of room? Yep, a negative pressure room. We need those germs going out of the building and not in towards the hallway. 64, a CNA notices that a patient's urinary catheter is resting on the floor while assisting with repositioning. What should the CNA do? A, hang the bag on the bed frame below the bladder level. B, empty the bag immediately. C, place the bag on the bedside table. Or D, replace the bag. Your patient's urinary catheter bag is on the floor. What do you do? Zilma and Kerdala, yes, you have it. It is A. We got to pick the bag up. We don't have to replace it. We don't have to clean it. We need to get it off the floor, though. So the catheter bag should always be kept below the level of the bladder and never touch the floor to prevent contamination and reduce the risk of urinary tract infections. The makers of the hospital beds usually have little hooks or little areas beneath the bed where you can attach a catheter so that it does not hit the floor. So they'll show you that whenever you get your orientation to your facility. 65, a CNA enters a patient room and smells smoke coming from a trash can that has caught fire. What should the CNA do first? A, run out of the building. B, activate the fire alarm. C, remove the patient from the room. D, ignore the situation. Well, if you do D, you won't be a CNA for long. I can tell you that. If you do A, you won't be a CNA for long. So process of elimination, what's going to be the answer? Is it going to be B or C? That's right. Whenever there's a fire, we race, we rescue first. So we have to do C. We have to get our patient out of danger. We have to remove them. So in a healthcare setting, fire safety follows the RACE protocol, which is rescue, alarm. That's when you pull the fire alarm after you rescue that patient who's in immediate danger. You close off the door. That's going to prevent the fire from traveling. Most of the doors are fire rated, meaning that it may take 1 or 2 hours for the fire to pass through that door. And then if you can't extinguish the fire, the E would also mean evacuate. You would have to evacuate to another floor, if not evacuate the building. The CNA should quickly remove the patient from the room to a safe area before taking the additional steps. 66, a resident becomes sexually inappropriate toward the staff. The best action would be A, laugh it off. B, ignore it and continue to care for that resident alone. C, insult them to stop it. Or D, set firm boundaries. You are going to find your voice as a healthcare professional. You're not going to let people abuse you, and you're not going to let people speak to you inappropriately. So it's going to be D. You're going to set those firm boundaries. Mr. Miller, I do not like how you're speaking to me right now. I'm going to leave the room, and when I come back, I'm coming back with my nurse. Use your team. So yes, clear boundaries and redirections maintain safety and professionalism. And as the nurse, if there is somebody else who I feel would be better suited for a patient who's being inappropriate, I will switch the assignments. But I'm also going to talk to that person first. I want to make sure that you feel supported and backed up, and that that patient knows that that activity will not be tolerated. 67, a resident is crying and says, I want to die. The CNA should A, promise secrecy. B, stay with them and ask about their plan. C, stay with them and notify the nurse. D, leave them alone to calm down. And I didn't want to share too many stories, but there was a adolescent who was Baker acted, but this particular hospital had closed down their Baker Act unit. And so they put somebody who needed to be watched because they had suicidal ideations. They left them on the regular floor. And one day she escaped her room when the other staff was busy because she wasn't on a secured floor. And she went all the way up to the top of the parking area, and she jumped off. And so if someone asks or if they say they want to kill themselves, yes, getting that nurse in the room is important, but you always want to ask about their plan because that person felt comfortable enough to tell you. They didn't tell me. When I come in the room, they're going to say, oh, no, nothing's wrong with me. I'm just joking. And so if you feel safe, you're going to do B. When a resident expresses thoughts about wanting to die, the CNA should take the statement seriously and remain with the resident. Asking if the resident has a plan helps to determine the level of immediate risk. The CNA should provide support, ensure the resident is not left alone, and then report the situation to the nurse immediately. Again, they found favor with you. They want to share that with you. When I come into the room, they're going to act like nothing's wrong with them and they have no plan. So get as much information as you can so that I can make sure I help to keep that patient safe. 68, a CNA checks a resident's vital signs and records the following. The temperature is 101.8 degrees Fahrenheit. The pulse is 108 beats per minute. The respirations are 24 per minute, and the blood pressure is 98/60. The resident appears flushed and weak. What should the CNA do first? A, offer the resident a snack. B, document the findings and recheck in 10 minutes. C, encourage the resident to walk in the hallway. D, report the abnormal findings to the nurse immediately. This patient had too many abnormal findings. So when I be like, hey, recheck, you recheck if it's one abnormal finding, but everything was wrong with this patient. Get your nurse in the room immediately. So it's going to be D. This resident had a fever, a rapid pulse or heart rate, and a low blood pressure. That could be, it could indicate infection. We refer to it as sepsis or clinical deterioration. These abnormal vital signs must be reported to the nurse immediately so the resident can be evaluated. 69, a resident's abdomen is rigid and they report severe pain. As a CNA, what should you do first? Do you access the resident's abdomen? Do you give a laxative? Do you notify the nurse? Or do you ask the patient about their last meal and bowel movement? Their abdomen is rigid and they have severe pain. You're going to see so much so fast. Don't be afraid to notify your nurse. So the fact that this person has severe pain, that's beyond constipation. They're having severe pain. So it's going to be C. You have to notify your nurse because severe pain could indicate an internal bleed, or whenever the constipation becomes so severe, it can cause a bowel obstruction. So you see something like that, the patient's complaining, that's above your pay grade, as I like to say. Get your nurse in the room so she can call the doctor. 70, a resident with dysphagia requests water but is ordered thickened liquids. The best response by the CNA would be to A, give the thin water to be nice. B, explain and offer the thickened liquids. C, sneak water when no one is watching. Or D, ignore the request, ignore the resident. So your dysphagia, DYS in front of a word means difficulty. Phagia refers to speech or swallowing. So this person who's having swallowing difficulty has been ordered thickened liquids. And if you do anything besides give them thickened liquids, you are not being a good caregiver. So yes, it's going to be B. You're going to explain the purpose of these thickened liquids because maybe they forgot. So residents with dysphagia are at high risk for choking and aspiration, which can lead to serious complications such as aspiration pneumonia. The CNA must follow the care plan and dietary orders, which require thickened liquids. And the speech therapist will let you know whether it should be a nectar thick or honey thick. And based off of that, if they don't have like they could be like little juices that are already pre-thickened. If they don't have that, you're going to use the thickener that's shown on the screen. It has a scoop, and you're going to add that to the water or whatever you're giving the resident until it's at the desired consistency. But that's how we keep them safe and help to prevent them from aspirating. 71, which is the safest way to transfer a bedridden resident from a bed to a jerry chair? The Jerry chair is that big recliner that has the tray table over it. And so, what's the safest way to transfer somebody who's bedridden? Is it A, pull them by the wrist? B, use the gait belt in proper technique? C, use a Hoyer lift? Or D, lift them alone quickly? I'm praying everyone gets this right. We're going to give you about 10 seconds to put your answers in the chat. Okay, I see a few answers so far. I see a B. And RM, you've been here for so long. Benjamin says B, RM says B, Sandra says C. We have a lot of B's. Sandy has it. Yes, it is C. You all, he's bedridden. Don't try to pick up a bedridden person with a gait belt. Use your Hoyer lift. All right, so it's going to be C. A bedridden resident who cannot stand or assist with movement requires a mechanical lift, such as a Hoyer lift, for safe transfer. Mechanical lifts reduce the risk of fall, skin injuries, and musculoskeletal injuries for both the resident and the staff. These transfers typically require 2 trained staff members to ensure safety. There is a poor CNA right now who is incarcerated in jail because I'm sure that her facility was understaffed. But instead of her documenting that she couldn't get the patient out of bed because she didn't have any help, she got this patient out of bed utilizing the Hoyer lift all by herself. The patient slipped out of the straps, hit his head, developed a subdermal hematoma. The patient died from the injuries. The CNA did not get an opportunity to fight for her license. She is incarcerated. So if they tell you that it requires 2 people, make sure you have the appropriate staff. And if you cannot get this patient up because you don't have help, don't get them up and document the reason that you didn't do so. The hospitals and these facilities have to be put back. All this has to be put back on them. There's no reason for that CNA who was just doing a job that she thought she was doing the best to be incarcerated. And no, the nurse did not go to jail with her. 72. A resident has unilateral leg swelling, warmth, and pain. What is most concerning? Does this patient have A, a possible DVT? Is this B, normal aging? C, congestive heart failure? Or D, a CVA? Unilateral, break those words down. Uni means how many? 1. Lateral refers to side. So one side, one leg is swollen. That more than likely means this patient has a possible DVT or deep vein thrombosis, which is a clot that forms in a deep vein, usually in the leg, especially after certain surgeries or injuries. A DVT is dangerous because the clot can break loose and travel to the lungs. So we say they have a pulmonary embolism. It can also travel to the brain and cause a stroke, or travel to the heart and cause a heart attack. So when we say that, hey, this patient's they're immobile because we're trying to rule out a DVT, is because we don't want that clot to start traveling. So keep them in bed. I know they don't want to be there, but whenever a patient tells you that one of their legs is hurt or is swollen, ding, 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 DVT, you don't say anything, go get your nurse in the room. 73 is long. Get your pens and papers together. A CNA records the following intake for a resident during breakfast. You're going to learn conversions in a few moments. Your resident had 8 ounces of orange juice, 6 ounces of coffee, and 4 ounces of water. So the first thing I need you to do is to total up all of your ounces. Now to convert your ounces to mLs, you multiply your total ounces by 30. I'm going to give you about 15 seconds to put your answers in the chat. Total up your ounces, multiply that by 30. All right, I see some C's coming through. So far, we just have two answers. Anybody else? I know. You all had to use your calculators for this one, and you're on your phone, so it made it more challenging, right? I have a D. I'm going to wait for three more responses. My D's have it. 18 times 30. So your total ounces were 18 ounces, and each ounce is the equivalent of 30 ml. So it's a 1:30 ratio. You multiply the total number of ounces, 18 by 30, and that should give you 540 mLs. Great job, team. 74. A resident with a tracheostomy has increased secretions. The CNA's priority is to A, remove the trach, B, encourage the patient to cough harder, C, maintain a patent airway and have suction equipment available, D, place them flat. And it's so scary when your patient with a trach just has all these extra secretions. They can still get pneumonia, they can have bronchitis, and they have a tracheostomy. They have a tube in their throat, in their trachea, and that's how they're breathing now. And this is your patient. What is your priority? That's right, Nate Carly. We're going to make sure they're positioned properly, and we're going to make sure we have some suction equipment nearby. As a CNA, you are not responsible for the suctioning, but you're to make sure that we have it at least in the room. So it is C. Residents with a tracheostomy are at risk for airway obstruction from mucus and secretions. The CNA's priority is to help maintain the clear airway, not by suctioning, but by making sure that person's in the proper position and ensuring suction equipment is readily available for the nurse or respiratory therapist. So let's say we have a new admission who has a trach. I'm telling you, hey, Margaret, we're going to have a patient arriving in room 306 in 20 minutes. She has a trach, so she needs suction. She needs a bag mask device. I'm going to tell you all this stuff. And in addition to your admission kit, you would have to set up the suction equipment. It doesn't have to be perfect unless you're a seasoned CNA, but it's going to make sense after a while. You're going to have the suction canister. You're going to have a wand, the little yanker, that's for their oral secretions. And then your nurse will get the rest of the stuff. But that's what we mean by when we say that you would ensure that the suction equipment is there and working. That is part of your role. 75. A resident weighs 176 pounds. What is the resident's approximate weight in kilograms? So we did ounces to mLs. That's one conversion that the CNA would have to know. In most of your facilities, the electronic documentation, when you enter the pounds, it automatically converts it to kilograms. But what you divide the pounds by is 2.2. So if you know the pounds, divide that by 2.2 to get the reading in kilograms. So let's see who can give me the right answer. I love this. I can tell when you all are thinking because the chats get slower and slower. Whoop, whoop, Amaray. Yes. So 176 divided by 2.2 equals 80 kilograms. Hold up, Maddie. I'm trying to get to your response. Let's see. Where's my Maddie at? Maddie, hey. It says, hello, pretty nurse. I passed my test yesterday. Congratulations. May God continue to bless you, grant you good health, and grant you a long life. Keep it going. You are a God gift to CNAs. Thank you. You have touched my heart, Maddie. I'm so proud of you. And if you're in Florida or wherever state you're in, once you've been a CNA for 6 months, most of your colleges have an accelerated path from CNA to LPN. So you can go from CNA once you have 6 months of experience, apply to their accelerated LPN program, and continue your studies and be a nurse in 9 months. And some people say, don't go to LPN school. Look, LPNs still have jobs, and they're now being allowed to work in a hospital. And once you become an LPN, you can bridge to RN. So you are still going to end up becoming an RN. It just depends on whether you want to go to school straight for 3 years or if you're okay using those bridge options. And so I can't wait to see what you do with your CNA license, and best of wishes to you and yours. All right, let's go to our next question. 76. A CNA notices that a resident receiving oxygen at 2 liters per minute via nasal cannula has removed the tubing and appears to be short of breath. As a CNA, what is your best response? Is it A, notify the nurse immediately? B, turn the oxygen up to 6 liters per minute? C, reapply the oxygen tubing and ensure it is properly positioned? Or D, document the observation? Now, this patient then took her oxygen off and now she's short of breath. What should you do as the CNA? Vivalin has it. It is C. So I know you want to notify the nurse immediately. But if I'm in room 50 and you're in room 1, it's going to take me a while to get to you. I need you to put the oxygen on while you're waiting for me to get there. So it's going to be C. The CNA should immediately reapply the oxygen tubing to restore oxygen delivery and then notify the nurse. You never change or adjust the flow rates. Regardless, while it says without a nursing order, you would not be changing the oxygen rates. That is a nursing or a respiratory therapist duty. 77. A resident's family asks you to explain the diagnosis. The best response is to A, ask the resident's permission before discussing the diagnosis. B, share chart details. C, guess to be helpful. D, refer them to the nurse. And we're going to speed this up a little bit. My son is coming in from New York. I let him travel to New York at 13 with a tour, and he comes home today. So 77, even if the resident gave you permission, that's outside of your scope of practice to discuss the diagnosis. You have to refer them to the nurse. So it's going to be D. Diagnosis/medical interpretation is not within the CNA scope of practice, even though you may have the right information. That's just not your job. You have to ask the nurse or ask the nurse to come speak to that family member. 78. A resident refuses a shower because they are cold. As a CNA, should you A, force the resident to shower, B, offer a warm blanket, warm a room, and then reschedule a shower if possible, C, chart that the resident is non-compliant, or D, skip hygiene for the day? And some of these residents never want a bath, so you can't just keep skipping the baths. That is a recipe for a lawsuit, because the bath isn't because they stink. The bath is also because we need to clean the germs off of their body, and we need to do a skin assessment. And so if that resident says they're cold, you're going to do B. Let's warm this room up and let's get this room warm, and we're going to try to reschedule the shower in an hour. Is that okay, Miss Lucas? 79. The CNA empties a urinary drainage bag and measures 650 mLs of urine. Later in the shift, the CNA empties another 450 mLs. What is the total urine output? So all you have to do is add. Is it A, 1,000 mLs? Is it B, 1,050 mLs? C, 900 mLs? Or D, 1,100 mLs? Yep, as a CNA, it's a lot of math. You're doing all the calculations. You have to let us know how much fluid the patient's taking in, how much urine they're letting out, the number of bowel movements. If they vomit, we even measure that too. And the reason why we do that is to make sure that what goes in matches what goes out. Otherwise, our patients could become dehydrated. And so for question 79, Yes, it would be 1,100 ml. So that means this patient's drinking some fluids. 1,100 mLs would be the total urinary output. Remember that accurate intake and output tracking helps to monitor kidney function and hydration status. So we monitor everything these patients take in, especially if you're in a hospital. Question 80. A resident has watery diarrhea and is dizzy when standing. The dizziness is most likely caused by which of the following? A, C. diff, B, overhydration, C, dehydration, or D, hypertension only. Diarrhea and they're dizzy? What do you think, team? Hey, Nadij, I haven't seen you in a while either. Hey. Some of you are like family members. I miss seeing y'all. All right, so we have an A as an answer. We have C as an answer. Let's see if we get a few more answers. Oh, we're all over the place. We got A, B, C, and D. So for 80, the answer is not A. Just because they have diarrhea and they're dizzy doesn't mean they have C. diff. But they have diarrhea and they're dizzy, which means that more than likely they are dehydrated. That's right. So frequent watery diarrhea can cause significant fluid loss, which may lead to dehydration. Dehydration can result in low blood pressure, dizziness, weakness, and lightheadedness, especially when standing. That would be the orthostatic changes. The CNA should assist the resident and report these symptoms to the nurse because maybe your nurse needs to get an order for some IV fluid. So patients should not be that dehydrated. Our next question is number 81. Which statement best describes the CNA role in care plans? A, write new medical diagnoses. B, change orders independently. C, follow assigned interventions and report the changes you observe. Or D, discontinue precautions when improved. So for example, your patient was on fall precautions and they haven't fallen in 2 days. Do you just want to remove the fall precaution signs? Absolutely not. So the best response for this one is going to be C. You follow what the interventions are that's in the plan of care and what your nurse tells you, and you document and you continue to observe your patient. 82. A resident's call light keeps being ignored by a coworker. The best professional action is to A, do nothing, B, confront your coworker, C, post about it online, or D, ensure the resident's safety and follow the chain of command to voice your concerns. Yeah, don't confront them. They're going to probably point the finger at you. So the answer is going to be D. The CNA's first responsibility is the resident's safety and well-being. So you are going to report it. You're going to follow the chain of command by reporting it to your nurse or the house supervisor. 83. A resident asks you to crush pills in applesauce. The best response is to A, crush them, B, refer her request to the nurse, C, hide the pills, or D, tell them to swallow the pills whole. And I have seen that happen where the nurse just leaves the pills at the bedside and the CNA walks in and the patient asks the CNA to do whatever with the pills. That is, of course, outside of your scope of practice. So the answer to 83 is going to be B. Medication administration, including crushing medications, is outside of your scope. Some medications must not be crushed because it can alter how the medication is absorbed or cause harm. The appropriate actions to inform the resident that the nurse will need to assist and notify licensed staff. If you are a med tech is separate from a CNA. So when you're taking your CNA test, you cannot give medications. However, in certain states, if you take additional training and you are allowed to be a med tech, you can then give medications. But as a reminder, for your CNA test, you cannot give medications. That is a nursing role. 84. While checking a resident during the night, a CNA observes that the resident's breathing is irregular during sleep with several prolonged pauses where no chest movement is seen. What condition does this pattern most likely represent? Is it A, apnea, B, sleep apnea, C, bradycardia, or D, tachypnea? And as I say these words, if it helps you, I want you to pronounce these terms with me. apnea, sleep apnea, bradycardia, tachypnea. If someone stops breathing during their sleep, then yes, it is B. It is sleep apnea. Sleep apnea is a condition in which a person experiences repeated pauses in breathing during sleep, often followed by irregular breathing patterns. Anytime somebody has an irregular pulse and irregular respiration rate, you're supposed to be counting those vital signs for 1 full minute. CNA should observe and report these breathing changes because untreated sleep apnea can lead to fatigue, cardiovascular problems, and decreased oxygen levels during sleep. 85, a resident has new difficulty swallowing and drools. This is most concerning because it could be a sign of, is it A, mild hypoglycemia, B, normal aging, C, possible seizure, or D, possible stroke? Yes, it is D, possible stroke. So sudden difficulty swallowing and drooling can be signs of a stroke or a CVA, which is a cerebrovascular accident. And we already talked about those stroke symptoms before. That's when you do your FAST assessment and you would get your nurse into the room. 86, a resident's vital signs are a BP of 130/78, 78 when they are lying. But when you stand them up, their blood pressure decreases to 102/60. The resident reports dizziness when standing. What is the CNA's best immediate action? Should you A, encourage the resident to walk to improve circulation? B, lower the bed? C, offer the resident water? Or D, assist the resident to sit or lie back down? Yeah, you got it. If a resident stands up and they get dizzy, we got to put them back in bed. It's going to be D because that indicates that they had a change in their blood pressure with the position change. We refer to that as orthostatic hypotension. And the safest action is to get them back in the bed and let the nurse come in and assess them. 87 is long. 87, a resident is ordered to drink 1,500 mLs of fluid daily. By dinner, the resident has consumed 8 ounces of juice, 6 ounces of coffee, and 12 ounces of juice. And you remember how we get from ounces to mLs. We have to total up our ounces and multiply it by what number? Now, once you have your total mLs, subtract that number from 1,500, and that will let you know how many more milliliters your resident needs in order to meet their daily goal of fluids. And this usually happens with somebody who is dehydrated, somebody who just doesn't consume enough food or fluid. We're going to mandate how much fluid they have per day. Or it could be the opposite. We could restrict how much fluid they have per day if they're fluid overloaded. All right, looks like I have a lot of D's. I have a B. Revealing the answer in 3, 2, and the answer is A. Let me make sure we have that one right. Let's go back. So 240, 180, 360 is 780. Let's go back. Yep, it is A, 720. What we usually do to just simplify life is that if a person's on a 1,500 ml fluid restriction or fluid requirement, that means that from 7 to 3, they get 500 mLs. From 3 to 11, they get 500 mLs. And from 11 to 7, they get 500. That makes it more bearable because we don't want to be forcing the patient to drink a whole bunch of fluids right before bed. But the answer to that question is A. 88, a CNA enters a resident room and notices the resident applying petroleum jelly to dry lips while receiving oxygen therapy. What should the CNA do? A, offer to give her a simple mask instead of a nasal cannula. B, increase oxygen flow. C, offer a water-based lubricant instead. D, allow the resident to continue using the petroleum jelly. Your residents on oxygen, their lips are dry. They have petroleum jelly and they're lubing their lips. Is that good or bad? Right? I see a D. I see a lot of D's. And so petroleum jelly is flammable, and oxygen is also flammable. So you don't want them using petroleum products when they have oxygen. So the answer is going to be C. Instead, your facilities are going to have water-based lubricants or lip balms that would be safer. So no, you'd have to tell them that they can't use the petroleum jelly because it's flammable, but you'd also be providing them with something that they could use. 89. A resident sleeping in bed suddenly makes gurgling noises and turns slightly blue around the lips. As the CNA, what are you going to do? A, raise the head of the bed and reposition the resident. B, turn the lights off. C, notify the nurse and wait for instructions. Or D, cover the resident with blankets. Gurgling sounds, and they are turning slightly blue. Your nurse is in room 50 and you're in room 1. So what do I need you to do first? Yes, first it's going to be A. I need you to get that patient positioned properly. Let's try to improve their airway. And it only takes a few moments, and then you're going to be able to call for your nurse. But if you wait for your nurse to enter the room before you do anything about their position, that could mean that they're laying there suffocating on their own secretions for 2 to 3 minutes. So sit them up and get the nurse into the room. So yes, it is A.
90. A CNA prepares to transfer a resident from wheelchair to bed. The wheelchair brakes are locked, but the footrests remain attached and positioned forward. What is the safest action? A. Leave the footrest in place. B. Move the wheelchair further away. C. Unlock the brakes. Or D. Remove or swing away the footrest before transfer. We'll give you a few moments to put your answers in the chat. And yes, the answer is D as in dog. Hello, Mandeep. So whenever you are putting a resident or a patient in a wheelchair, those footrests can pose a tripping or a fall hazard. So you should either remove them or position them so they are out of the way, because footrests can create hazards during transfers and should be moved so your patient doesn't have to step over them to enter the chair. As a reminder, if you want to watch all of our CNA skills step by step, you can scan the QR code that's on the screen, or you can go to our YouTube channel and just look for this thumbnail, this image, and that's going to help you become more knowledgeable and pass your skills test too. Now, this makes me smile. I am Auntie Eunice. I love being your auntie nurse. So Eric says, I made an 82% on an NACC exam. I'm so proud of you. Congratulations. And thank you for tuning in with us. All right, let's go to our next one, everybody. 91. A nurse reports that the resident has dyspnea when walking. What does this term mean? Is it A, chest pain, B, difficulty breathing, C, fast breathing, D, no breathing, excuse me, or E, both B and C? Don't add anything to the term. If you know what the prefix DYS stands for and the suffix PNEA stand for, don't give it more meaning, okay? So what does dyspnea refer to? This person is dyspneic when they are walking. You are correct. It is B. So I know sometimes we want to say, oh, they're tachypnic. No, we didn't say their breathing pattern was faster than normal. We're saying with the DYS, they're having difficulty while breathing. And that is going to happen a lot with patients who may have respiratory illnesses or cardiac illnesses. They're going to become winded or short of breath when you get them up to walk, even if it's just walking them to the bathroom. So be very patient with them. As a reminder, DYS means difficult or abnormal. And whenever you see PNEA in the term, that's referring to breathing. 92. A patient's diagnosis includes arthritis. What does the suffix itis mean? Is it A, infection, B, swelling, C, inflammation, or D, fracture? Arthritis. What does the itis refer to? Yeah, and that's tricky because we want to think that it means infection, but it's actually C, inflammation. And yes, something can be inflamed because it's infected, but it could just be inflamed as an injury response. So when you see itis behind a word, it means that there's inflammation. Arthritis would be inflammation of a joint. 93. A resident with polyuria is likely experiencing which of the following? Is it A, painful urination, B, no urination, C, pus in the urine, or D, excessive urination? Yep, you're learning your medical terms, your prefixes and your suffixes. Of course, urea refers to urine, but what does what does that prefix mean? And for this one, poly refers to excessive. It is D. That's right, Mary. So the prefix poly means many or excessive. So if you see poly in front of a word, that is more than normal. When would a patient be experiencing polyuria? Usually whenever their diabetes is uncontrolled or if they're having other kidney issues. So if your patient's going to the bathroom more frequently, it could be a side effect of diuretics, but we wouldn't call that polyuria. We call that diuresing. We're getting rid of that excess fluid. So if they're not on diuretics, this could often be caused by somebody whose blood sugars are high. 94. A resident diagnosed with hepatitis has inflammation of which of the following? Is it A, liver, B, heart, C, kidneys, or D, lungs? Good morning, Amelia. I think I didn't say good morning to somebody. Let's see. Miss Young Sniper, thank you for taking your work break with us. I hope you have a wonderful work day. All right, and so if a resident's diagnosed with hepatitis, that means that they have inflammation of the liver. When you see HEPAT in front of a word, that refers to the liver. So hepatitis is inflammation of the liver, and that can occur due to cirrhosis. It can occur due to hepatitis B. Hepatitis B is a bloodborne pathogen that your facilities will offer you a vaccine for. And there's also hepatitis C, which can be transferred through stool and other bodily fluids. 95. The nurse documents syncope. What does this term mean? Is it A, seizure, B, headache, C, light stroke, or D, temporary loss of consciousness? You're reading a chart and you see a word that says syncope. What does syncope mean? If you chose D, you are absolutely correct. Syncope is the medical term for fainting or a temporary loss of consciousness. It's not that they had a stroke. If you stand up for too long and lock your legs, the blood flow can leave your heart and your brain and go down to your legs. That's why they tell you never to stand in place for too long, kind of like march in place. So when someone has syncope, it's usually caused by reduced blood flow to the brain. It's often preceded by symptoms such as dizziness, lightheadedness, or weakness, particularly when standing up quickly. If a patient's on a blood pressure medication or if they're on a diuretic, Especially if those medications haven't been regulated properly, they can have syncopal episodes too. So it's commonly seen on cardiac units. Whenever you're getting a patient up out of bed, you don't have them move quickly. You sit them up over the edge of the bed for a few minutes first, put their shoes on, and then stand them up. And upon standing, you'd ask, are you dizzy? And if they say yes, you get them back in the bed. If they say no, then you can proceed with taking them wherever you're going to be walking them to. 96, proper order to remove PPE to reduce contamination typically begins with which of the following? Is it A, do you remove your mask first? B, gloves first? C, your goggles and face shield first? Or D, your gown first? Which of these items would be removed first in order to reduce contamination? Right? Revealing the answer in 3, 2, and look at those gloves. Yes, we're going to remove those gloves, Amelia. So it is B. The gloves are the most contaminated, so they come off first. And depending on your facility and the way that they train you, when you take off your gown can pull off your gloves, but the gloves have to come off before you touch your face, before you touch your mask, and before you touch your goggles. So gloves, which are the most contaminated, are always removed first, then the gown, followed by what's on your eyes, and then lastly would be your mask. And you finish it by washing your hands. 97. A residence chart says orthopnea. Say that word with me, orthopnea. What does this term mean? Is it A, difficulty breathing after exercising? B, fast breathing? C, breathing difficulty while lying down? Or D, no breathing? What does orthopnea mean? All right. I see some answers coming through, and this one's a little bit trickier. Orthopnea is related to position, so a shortness of breath whenever the resident's lying down. The answer is C. So whenever a person is lying down, they can become short of breath. So when you have a patient who has CHF or maybe like emphysema or asthma, they may ask for extra pillows so that they can sit upright more. Here's your rationale. Orthopnea refers to difficulty breathing when lying flat, which improves when the person sits up or stands up. This occurs because sitting helps to expand the lungs and to reduce the pressure on the chest, thus making it easier to breathe. Residents with orthopnea often sleep with extra pillows or in an elevated position to reduce breathing discomfort. 98. A CNA assistant with bathing observes yellow discoloration of the resident's skin and eyes. The nurse documents jaundice. What does jaundice indicate? Is it A, skin infection? B, dehydration? C, liver or bowel problem? D, fever? You are absolutely correct. It is C, liver or bowel. Jaundice is a condition in which the skin and the whites of the eyes appear yellow due to buildup of bilirubin in the blood. Bilirubin is a substance produced when red blood cells break down and is normally processed by the liver and removed through bowel. When the liver is not functioning properly or bowel flow is blocked, bilirubin can accumulate, thus resulting in jaundice. Question 99. A resident is on strict INO. The best practice is to A, estimate intake, B, measure all fluids in mLs or cc's and record promptly, C, measure all fluids in ounces and record promptly, or D, skip water because it's hard to measure. And this confuses the best of us. So, whenever we are monitoring or we're measuring our patient's fluid intake and their output, we have to use metrics. So, we're going to measure in mLs and cc's. The answer is B. We have to get the smallest measurement possible, and an ml is smaller than an ounce. Here's your rationale. When the resident is on strict intake and output or INO, monitoring all fluids the resident consumes or eliminates must be accurately measured and documented in milliliters, which would be mLs, or cubic centimeters, cc's, and those are equivalent amounts of fluid. Healthcare facilities use metric measurements because they are standardized and allow the healthcare team to closely monitor hydration status, kidney function, and proper fluid balance. Recording the amounts promptly and accurately helps ensure proper medical decisions and patient safety. Your facility will determine whether you document in mLs or cc's. Again, they're the same exact amounts of fluids. It's just whichever one the facility prefers. Going to our next one. Our last question, everybody, is question 100. A CNA checks a resident's vital signs during the evening shift. The resident suddenly appears confused, restless, and is pulling at the bed sheets. The vital signs are temperature 100.9 degrees Fahrenheit, blood pressure 98/56, pulse is 98, respirations are 26, and the oxygen saturation is 92%. So I'm going to give you a few moments just to look at those, which are abnormal. We have 100.9, 98/56, a pulse of 98, respirations 26, and an O2 sat of 92. What is the most appropriate immediate action for a CNA? Is it A, cover the resident with additional blankets so they can rest? B, offer the resident water and reassess in 1 hour? C, help the resident sit upright and ensure oxygen equipment is positioned correctly? D, keep the resident safe and notify the nurse immediately. As a CNA, you have to know the normal ranges for vital signs, because whenever something is abnormal, you're going to make your nurse be made aware. We do often ask that you repeat vital signs, but when a resident has more than one vital sign that is not within normal parameters, it's rare that two pieces of equipment would be malfunctioning or that you didn't do two things correctly. So in this case, the best response, that is right, Marine. That's right. It is going to be D. We have to get that nurse in the room right away. So their temperature was 100.9, which indicates a fever. For elderly patients, they don't have these high temperatures like 103. For them, 2 degrees above their baseline could be indicative of a fever. It could also mean they're overheated. They have on too many blankets, but that's why you recheck. The blood pressure is 98/56. Well, that's lower than normal. So they're febrile, they're hypotensive, their pulse rate of 98 was okay, because remember the range is 60 up to 100. But they're tachypnic because their respiration rates is higher than normal, is 26, and then they're hypoxic because their O2 sat is 92%. That's way too much going on. Get your nurse in the room. These findings together may indicate infection, hypoxia, or another acute medical problem. The CNA's priority is to ensure the resident's safety and report these abnormal findings immediately so the nurse can assess and intervene. Look, I am so proud of you all. I want to thank you all for your support. Many of you all have purchased our CNA exam prep book. It has practice questions, it has terminology, abbreviations, step-by-step skills, and it's also easy to read. I wanted to make sure that it sounded the way that I talk in the real world so that you'd be able to understand the terms. If you're interested, you can scan the QR code that's on the screen, or you can go to our website, which is fltraining.com, to get your copy. I want to thank you all for watching, and I'm going to stay on for a few minutes to see what questions you have, and I will answer them in the chat. If you all are interested in practicing with our CNA flashcards, you can practice for free. You can go ahead and scan the QR code that's on the screen and get started. I partner with Brainscape in order to offer you an innovative and interactive way to prepare for your CNA exams. So let's see what questions you all have.